Hello, everybody. Good morning, good afternoon, good evening, in the words of the great Dr. Tedros. Thank you so much for joining us today for another episode of Coding with Christine Hall. I have my good friend Stephanie Allard here with us today, and we're going to talk about Path and Lab on this wonderful roof over your head day. I don't know how that works, but roof over your head day. I was telling Stephanie earlier that today in history, in 2017, was the very first pizza party in space.
Yes, so we need to know where this pizza came from. That's the big
If it's not
question.
from New York, then it's not real
Exactly.
pizza. Yeah.
Exactly.
Yeah, you were talking
Especially
about
back
something.
then, you said 1920?
No, no, no. 2017.
Why did I think okay.
We didn't have a space station in 1920. Oh my gosh, is it getting closer to the holidays? Because I kind of feel like the weight of the year is just kind of settling in on us.
Yeah, yeah. Yeah, no, you're right. That definitely wouldn't be because I'm thinking to myself, what kind of pizza existed then? But yeah, no, they weren't even in space then. So so it could have been New York pizza.
It probably was New York pizza. I remember I lived in the Bahamas for a few years, and that was one of the big things is like we would all fly over to the States and buy mass amount of pizzas to take back with us and put them in the freezer. So
Yeah.
can't mess up pizzas. Just can't.
Yes. No.
Anyway, let's talk a little bit about the path and lab section of CPT. So I feel like unless you have a lab in your organization or your infectious disease or rheumatology, endocrinology, some of the other specialties may not really have a lot to do with this section unless you're specific. Uh, but you and I are both seeing where some of these labs are really coming into play now for specialty providers like urology or um, what was
Wound.
the other one?
Wound care.
Wound care. Absolutely.
Yeah. Yeah, and it's one of those things where I'm finding that I okay, it may be tied in different ways, but one of the things I'm wondering, I guess I should say, is that if different practices are purchasing this equipment to run these labs as another avenue of reimbursement.
Hmm.
I was just looking through the final rule again this week, and we continue to see decrease in reimbursement. And one of the things that worries me so much about people who dabble into these other areas is that I think that they really tend to look more on the clinical side, and they're not looking at what that means in the other half of the industry and for compliance and, billing, the accuracy of billing. And, we unfortunately work with a lot of clients who end up in bad situations due to some of those types of decisions.
Absolutely. And it's we're seeing this more and more as we move forward. There's always been in this industry salespeople who have come in with, if you buy this new piece of equipment, you can test this. I mean, we saw it on in the news with some of those that they got an amazing machine with a droplet of blood. We can tell you absolutely everything without mentioning any names. But and then providers, they really want to be able to care for their patients in the most non-invasive way and with the most accuracy. We're seeing that a lot with genetic testing. They're able to see what type of medication responds better with your genetic makeup, and you know even from a mental health perspective, what antidepressant is better for your chemical makeup rather than somebody else's. And that's all well and good. But we've got to remember that not all payers have gotten to that point yet where they have also seen the value of that type of medicine. So while your vendors or the manufacturers or the test the people who actually own the test, the proprietary labs, where they're seeing the value, the payers just they aren't there yet. And
Yep.
that creates a big disconnect when it comes to billing, or it comes to what codes do we use with some of these tests that are out there.
Yeah, yeah. And, one of the things I'm finding too, well, first of all, with some of our clients that have current issues, it's because I look at it from the perspective of technology being ahead of where we're at from a research perspective, which they
Mm-hmm.
can then use to prove, the outcomes and things like that, like you were referring to as well. So when we don't have that hard data yet, we're finding that for example, the urine panels that are being done right now for, UTIs, it's
Mm-hmm.
great from a patient treatment perspective. And then, even going further, like you said, looking at, okay, how do they respond to different antibiotics? This UTI is not getting better. But when we look at the processes in place to report CPT codes, it shows that as a part of the application, they have to show the research behind it and, the data behind it. And at this point, I'm finding, CMS just isn't there yet. And neither are the other payers. They're not accepting it yet. I don't know
And
why. I can't speak to that part of
well,
it. And I'm not clinical, but they're not there yet.
I was about to say it might take a little bit of intervention from those societies and associations, those clinical society and associations, to really push the value that is there. Now, that being said, I think sometimes our providers, they miss the idea that not everything should be paid for by insurance. So I know that I personally have had a lot of genetic testing done to find out a little bit more about some of the genetic conditions that I have. And I understand that that's not going to be covered by my insurance. But the value of knowing, and the value of being able to give my providers that information of how to treat me, or what exactly are they treating, not just a bunch of symptoms. I feel that there's value in that. But providers, again, have to be the one to initiate that conversation of, while I feel this is good medicine, it's probably not covered by your insurance.
Well, and when you look at the patient population where we're seeing a lot of issues with this, it's one of those things where, for the UTI panels, for example, or even the wound panels, different things like that, it's with patients who don't have, a lot of money. Some of them may even be dually eligible where they've got Medicare, Medicaid. So at that point, it's not a situation where the patient's number one could afford it, or where you're
Mm-hmm.
even legally allowed to bill them for different services. So that's another issue I see happening here. While it works, while the results are there and the doctors are happy with the results, we don't necessarily also have that concierge type scenario where they can afford to pay that out of pocket. And also, Christine, I know we talk a lot, especially on Sean's podcast, about this too, but that also completely eliminates the conversation about these device companies and what they're telling these providers. They
Yeah.
think we purchase a machine and we use it. Maybe they're aware of CLIA and all of that type of thing, which is great. But again, compliance is always here on the side, and we're always tending to be left out. What does the rest of that cycle and that picture look like?
You hit it on the head. What I see is, again, you and I, unfortunately, by the time that they bring in a compliance consultant to assist, it's usually driven by, I got a letter from
Yeah.
someone, or I
Oh
have to
yeah.
account for my actions. However, we talk a lot about compliance and having that compliance in place, and not only just to make sure that we're doing it right, but I know that you and I both do some sort of cost analysis. Okay, so here's how much the machine is going to cost. These are the codes. However, only one of your 17 insurance companies cover it. So do you feel that your patient population, which is partly dual enrolled, partly marketplace, are that demographic of patients going to be able to afford out of pocket the cost of you to perform these tests and to actually make a profit and not be in the hole? So looking at that from a total cost analysis, yes, it's good medicine, Yes, it might have a CPT code. No, none of your payers are going to pay for it. Are your patients eligible? Can they pay out of pocket? Do they have the resources? What is your population base? What does that look like? And then be able to really bring that data to the table from a compliance perspective and say, you know, you're not going to get a return on your investment. But if you're just doing this for good medicine, and then, get into all of the anti-kickback, if we're going to do it for free and nobody else is doing it for free, how does that affect us? Does council need to get involved to opine upon that? So before you commit or invest in these types of equipment or to do some of these unique panels, it might be worth it to hire someone to do that cost analysis for you and see if it really is going to benefit the practice in the way that you think that it will.
Yeah, and Christine, it's important to hire someone that is not recommended by the device company or the manufacturer. That's extremely important. There's
Oh
so
my
many, I had a conversation with someone yesterday and it wasn't about lab, but I couldn't help myself because they kept questioning me on the accuracy. And they're like, but so and so does this and they're a national company. And I just flat out said, look, it's wrong. I understand you're telling me that that's what they're doing, but they're not compliant and they're going to be in trouble. And I'm showing you in black and white writing why that's not correct. Now,
Mm-hmm.
one of the other things with that being said, right.
Oh, it looks like we're having a little glitch there, Stephanie. Not sure if it's on my side, but when we get you back, we will revisit that. One of the other things I wanted to explain while we were chatting is that when we're talking about panels, um, there's a lot of new panels that are out there now, PCR testing panels, and we're not talking about just the regular panels that you see in the CPT book. So your CMPs, your BMPs, your CBCs, your general exam. Oh, it looks like Stephanie logged out. She's going to be coming right back to us. But when we're looking at those panels as they're billed, now it's important to know your BMP. Oh, her internet went out, but she's going to be coming back. Your BMP, your basic metabolic panel, well, those are 8 of the most common tests. Now, remember, the CPT code that represents that BMP or that CMP, right? The complete metabolic panel, which is about 12 of those tests, all 8 from the basic plus some other tests, that the American Medical Association has worked in collaboration with all of the specialty societies, associations, and these are the standard of testing. The CMP, the BMP, they are the standard of testing. Potassium, glucose, sodium, chloride, carbon dioxide, calcium, those all paint a picture of a patient's general health, right? So it goes over a lot of the different organ systems. Now, when a provider tries to carve one of those tests included in a panel out, there needs to be good justification as to why. So I worked on a case not so long ago where the provider themselves was carving out one of the tests inside of a panel. I think it was the chloride test. And they said, well, we don't need that for our demographic of patients. Well, instead of putting together oh, there's Stephanie. Stephanie, we're
We're
going
having
over
all
some of
kinds of
these.
issues today.
That's okay.
My internet went down.
It's cold outside. Internet
I know.
sometimes doesn't like it when it's cold outside. But I was talking about the panels in CPT, the CMP and the BMP specifically, and how, that is the standard of medicine. Those are the basic tests that we need to get a general picture of a patient. And that also they cover a lot of different organ systems and conditions that might be affected by deterioration of one organ system or another. It's the standard of medicine. So when we carve out one of those, like the chloride test, and we say, well, we don't need that. it's good to have a policy in place to explain why, out of all the standards of medicine, your patient demographic doesn't require that one test. Not saying that your demographic couldn't, but to have a good reason put in place in the event of an audit from a payer who might be saying, listen, you're unbundling things to try to get more money out of us. This is the standard. Why aren't you billing for that one test that's included in the panel that now unbundles that entire panel, right?
Yeah, and you know what that's bringing to my mind is the situation, especially in pediatrics now, when we've had the implementation of these newer tests that can do, flu, RSV,
Mm-hmm.
COVID, they can do multiple things with one test, but the practice is like, oh, well, I don't purchase that one because then I can count them all and I'll be at a 4 because I gave an antibiotic. And, I think that maybe we're not there yet where that's going to be questioned by payers, but over time, I can see that being questioned because a lot of times I'm hearing verbally, it's one of those times where you want to plug your ears, but I'm
Mm-hmm.
hearing verbally from some people, well, we don't want to purchase that if it counts as one. That's just one test ordered.
And we got to remember that medical necessity is always the overarching criterion. So, not just for Medicare, not just for Medicaid, but if you look at your state statutes, each state also says that's the goal, that's the drive. You just can't file insurance because you make more money. It's not at the convenience of the patient, it's not at the convenience of the provider. It's to assist in an illness and injury, to maintain, to diagnose, to treat, to a malformed body member. All those things that we hear federally from the payer's perspective in the contracts to the state laws, right? So there is a responsibility there to make sure that if you're not purchasing the test that includes that A, B, influenza, RSV, even now they have one that has COVID in it, one test to test for many of those variants. If you're not using that why, maybe you have a policy in your organization. Maybe it does come down to finances. Maybe your distributor is able to give you those individual tests at a cheaper rate. Not that that's going to support medical necessity, friends, but there's some answer there other than we're doing it to count it as 4 tests. We got a moderate, we got a antibiotic issued to the kid. We're going to be, reporting this as a higher level of service than what was actually needed for this particular encounter. So, our
Yeah.
great Lexi's not here with us today. She's not feeling very well. And she also went to the doctor, and I'm sure that they ran some tests. And I can't help but think, could they have ran one test to answer many questions, or did they do that with her? Again, I don't know. I won't know till she comes back and to see if that actually happened. But
Yeah. Yeah. Well, and when you're talking about medical necessity, I think it's something that is important to highlight as well because there's not enough focus on that right now. When we look at first, let's say from the practice perspective, and I know you and I were talking about, the diagnoses that are linked to everything. I
mm-hmm,
find a lot of times, for example, I was auditing and working with a client in NextGen, and a lot of the systems have the same capabilities. So I'm not just picking on NextGen, but when your workflow and when your system allows the user to go in and select all diagnoses to link to your tests because it's easier from a workflow perspective, and they don't have to individually link or click an extra 5 times. I get it. I get that that's frustrating. I understand that. But from a compliance perspective, that is out of bounds when we go back to that documentation to look for that documented intent to order. And a lot of the providers I work with just think, okay, we've got an order, we have the signed requisition form, we have the results, we're good. But
mm-hmm,
when the payers want to audit, they actually ask for those notes from the office visit, from the face to face visit. What did the provider say that they're ordering these for? And then we've got, 10 diagnoses with chronic conditions attached to something. that they, or, acute problems they had 10 years ago because they were never removed from an active list. So that causes a lot of issues on validation.
I saw that recently on a preventive visit. Patient came in for their annual preventive visit. And then for diagnosis, you've got your Z code, Z00.00, without any findings. And then underneath it, it said the patient has diabetes followed by endo, hypertension followed by cardiologist, arthritis followed by rheumatologist. And attached to each one of those diagnoses was a CBC, a CMP, a urinalysis, and an EKG. Now, if we go back to our evaluation and management guidelines, a condition that is simply mentioned as being followed or treated by another provider doesn't qualify for a separate E&M visit, or doesn't add to the level of an E&M visit. So when they're telling us with these diagnoses that someone else is managing or handling those conditions, the question now arises as to why did you order all of these tests, which from the US Preventive Task Force, there's very few tests that are allowed to be ordered just for preventive purposes. So you're assigning a diagnosis of diabetes and hypertension and arthritis for the tests that were ordered. I don't know how you're going to be able to manage hypertension from a urinalysis. I'm not clinical though, so don't ask me. But from a payer's perspective, I can see where there may be some concerns that we are just where we are just adding diagnosis to try to get things covered. Does that make sense?
Oh, yeah. Yeah, because, how many times do we also go into a practice and they say, oh, well, for that test, we always use this diagnosis because that pays. And they don't have coding staff. They have someone who's data entry, maybe with some billing knowledge, and they just know that gets that paid. They're not paying attention to validating from a coding perspective within documentation, from a
Well,
compliance perspective.
the small practices don't have coders. And as a matter of fact, they're
Or
letting the
hospitals
EMRs,
nowadays. Even
yeah,
hospital systems don't.
they're letting the EMRs code everything. That's a tool. It's
Yeah.
simply a tool. How many times have you written a Word document and you've run it through the grammar check, and it comes back and it makes all of these different recommendations and suggestions, and sometimes even changes the meaning behind that Word document or that paragraph in that Word document? It's just a tool. And I think providers are not thinking this through sometimes, that their EMRs are just a tool. They're not a guarantee that we're submitting the right codes in the right order, the right information. Even the best EMRs out there are still limited to just being tools.
Well, and I think it just shows in general the complexity of what goes into coding and compliance. Because every time I deep dive into another one of these subjects, I always think, it reminds me of these education sessions where I'm coming in and I'm the bad guy and I'm just asking for so much more stuff. They're already dealing with the entire administrative side. They are irritated that they're having to document to payable scenarios or situations or policies or whatever. And then we're coming in here and saying, hey, this is what you put in your note. I can't tell what's going on. Or you did this out of convenience and now we've got a compliance issue. And
Mm-hmm.
that's something too, that's one of my frustrations actually, when we even look at the way that EMR systems are built. And, I personally, so when I do an audit, I look at the outcome of, okay, we've got documentation, coding, charge entry, um, and then use of the EMR, if we focus on those four things. And then
Mm-hmm.
we've got to see, okay, what's the solution based on the issues we found? And when I find issues based on using an EMR system, and with some clients, with one in particular, I worked with them for years. I got very close with their staff that worked in their EMR and even their vendor. I deep dove into a lot of the templates and the way that it was built. And it's like, I don't understand why there's not a stronger compliance, existence in these companies. There's a reason that certain things shouldn't even be available to a provider. It doesn't matter if it's out of convenience, if all it's doing is hurting compliance on the back end.
I almost wish that we could go back to the old soap note and not have all of these clicking box options. Now, I
Yeah.
mean, I get it. The medical record is not just for financial purposes, but the
Right.
medical record has gotten so far away from continuity of care. When I read these documentations and there's, inconsistencies, patient denies and then the patient states, and there's such solid inconsistencies there that it shows that the integrity of these EMRs is sometimes just click all the boxes you can, and more is not better. More is confusing sometimes.
But
For,
now
for,
I'm even seeing less. I'm seeing less. I have looked at notes recently that I go into the treatment plan and it says 2 words, and I'm not kidding, being treated. And it's like, okay, that's not the alternative here that we're looking for. Because yes, we've got note bloat, but I'm also seeing, I'm gonna say maybe people who are burned out, they're sick of it. The providers, they want to focus on clinical, and now,
yeah,
there are all of these other things that have to be clicked and thought of, and
I had
just
another example I wanted
another
to
issue.
share. It's just so let's kind of get back to one more thing with Path and Lab. I think it's important to remember that we said medical necessity, but when we're ordering these tests, there's an obligation. There's an obligation to review the test that you're ordering. There's an obligation to do something that is out of range or that is concerning. So the provider either can say this is a normal range for the patient, or the provider can say we're going to treat this condition based on the values that we've seen. Sometimes we have patients that come in and they'll ask for a test and there's no reason. I read a chart recently that the patient came in and they wanted to have a COVID test done. They taken one at home and it was negative. They are no longer symptomatic. There was no exposure to somebody. However, they just wanted to see if the cough they had 2 weeks ago could have been related to COVID. They're not symptomatic anymore. They want a COVID test. What are we going to do with the results? First of all, they're more than likely going to be negative because there's no signs and symptoms, no indication to support that being done. But what about also the fact that now the insurance company is going to pay for something that we're not going to use for treatment purposes, we're not going to use to make a condition better or to change a treatment plan for a patient? It becomes a problem when we overtest, and when we overtest and then we don't follow through.
So one thing that I always find interesting, and this comes up with the way we always say, we live in a pay and chase environment, right? So they're going to bill that claim. They're going to get paid if that biller knows that right diagnosis. Sure, they'll get paid for it. But look at the situations that you and I have even been dealing with in the past 2 months. We've got
Yeah.
situations now where the labs are in trouble. And based on the labs being in trouble, they're looking at the provider practice, looking at their notes, looking at their indications for these tests. And, a large part of that was actually, and I should say is because they're still in the middle of it, is that question of what are you doing with the information? You're saying this is not for screening purposes, but you're not established with the patient. You're not following up at all. If you have an abnormal result, you did nothing with it as far as, documenting communication. The one situation I'm dealing with that's pretty messy right now, I don't even know if they have a way to contact the patient after they do the testing.
Oh
So
my gosh.
yeah. So, that's a big question there. And, when tests are ordered, there's a lot of focus on that front end, but not that back end, like you're saying. And I like the word in this situation, analyze. So what are you doing to analyze? And Shannon DeConda actually drilled that into our head early on with 2021 E&M. That the focus in that middle column is not just, okay, yeah, I've checked all these boxes. You're analyzing it. What are you doing with the information? How are you
Right.
treating the patient?
Well, my friend Dr. Rosenstock, he is a podiatrist, but we're friends. So if I did have a brain MRI, I could go to him and say, "Hey, Dr. Rosenstock, would you read my brain MRI and tell me what's wrong with my brain?" He's more than capable of reading that MRI. But what's he going to use that for if he's there to treat my feet? Right? So
Yeah.
that may not be something that is valid or relevant. Like you said, the analysis, what is that going to be used for by that provider? Or another thing that I see, Stephanie, all the time is that providers will have a standing order in place for new patients to come in and have labs done before they establish with the provider. So when they have that new visit, those labs are available. Very concerning because first, there's no established relationship yet. There's no medical necessity for those tests. And a lot of times the practices have a cheat sheet with diagnoses that cover these tests, and they will assign these diagnoses to get the test paid even before the patient has come in and established a relationship with that provider. And from a clinical perspective, I can see that the doctor says, I need labs on the first visit, even if they're endo or rheumatology. But if you've not established that relationship yet, how do you support medical necessity for those?
Yeah, and that brings to mind standing orders, which we love. And there there's situations where I've worked with clients where they'll say, "Oh, well, what about those standing orders?" When I'm asking, "Where's the medical necessity? I need to see why this was ordered." Well, they were seen by a nurse before. But we're talking about complex testing here. We're not even just talking about a urine dipstick. We're talking about
Right.
complex testing, and they've seen clinical staff, not even seen a provider, and we don't know what they did with the information. So, yeah, that's a large part of it.
Um, we're at our time, but I do want to say, Stephanie, I think that with all of the revelations that have come in recently about lab tests, about the PCR testing, the panel testing, medical necessity, I think that 2025 is the year that we've got to be a little bit more diligent as we're looking at these labs, as we're looking at how they're used to treat the patient, and start to anticipate that if we don't start dotting our I's and crossing our T's, we may have to answer for this payment a little later down the road, and that might hurt.
Yeah, it will hurt. I can guarantee that. If it's found, it will hurt.
Well, I want to make sure everyone has your contact information. Please, if you have any questions, reach out to Stephanie Allard Consulting. Congratulations on that, my friend. I'm
Thank
so
you.
very proud of you.
Thank
Stephanie
you.
now has her own consulting firm and can help you with any of your compliance needs, your coding needs, anything that you would need from that administrative perspective. We talked about cost analysis today. We talked about, making sure that you've analyzed what is medically necessary, what isn't, some of those opportunities that you may be missing. Reach out to her. She's got all the answers for you. And you're taking new clients now, right?
Yes, yes, absolutely. So check out the
Awesome. Awesome.
website. There's a newsletter on there. I do also have a membership, which I know a lot of us do.
Yeah,
But there
yeah.
is a membership on there to focus on coding questions, but also putting a twist in there towards mentorship as well. I get a lot of
Oh, that's
questions about
wonderful.
personal and professional, development and what you can do to move forward. So I'm hoping to help some people in that area as well.
Well, I know that you help a lot of us out all the time, and I really appreciate you being on the show today. Um, we have another episode coming in 2 weeks. Please feel free to join us at that time. It's been a pleasure, everyone. Have a
Thank you,
great day.
Christy.
seem to be having the same technical difficulty we had before, so working on it.
Thanks for watching.